So today we will be discussing about chronic suppurative otitis media. So today's class will be on the tuberculopanic disease or the safe type. So these are the topics which we will be brushing through today. It is the definition, pathology, clinical features, investigations and treatment. So if you see the classification, there is an old classification and there is a new classification. So the old classification which is being used, which was being used is safe type and unsafe type, or the other name for safe type is tuberculopanic disease, and the other name for unsafe type is tick-borne disease. And whereas if you see the new classification, so there are 5 types. So the 5 types will be the healed chronic otitis media and mucosal chronic otitis media, active and inactive, and squamosal chronic otitis media, active and inactive. So if you see here, they have added one extra classification that is called as healed chronic otitis media. Means any patient with history of previous chronic otitis media and there is a perforation for that patient and that perforation has healed on its own. So that is called as healed chronic otitis media. So and even if you see the term has been replaced from chronic suppurative otitis media to chronic otitis media. Okay, so that is a classification change which is being made in the new. So if you see the definition, so the definition for chronic otitis media is nothing but long-standing infection which is involving the miliary cleft, either the miliary cleft in part or the entire miliary cleft. And if you see the perforation, there will be a permanent perforation for the patient. So this is the definition for chronic otitis media. And this classification, I hope everyone understood. Anybody is having doubts with this classification? So the safe type of the tuberculopanic disease is called as mucosal, and the tick-borne disease or the unsafe type is called as squamous. And each again mucosal and squamous has active and inactive. So here also for squamous, active and inactive. So active means there is an active inflammation going on in the miliary cleft, and so that will be characterized by persistence of inflammation of the mucosa, and also that will be characterized by presence of discharge. And in squamous also, active and inactive means, so there can be a retraction pocket or marginal perforation along with discharge and cholesteatoma. So that will be active. So inactive means there won't be any discharge, there won't be any cholesteatoma, there will be just retraction. Okay. So for your level, if you know this old classification, it is enough. But in case somebody asks you a new classification, then it will be better if you know this classification. Okay. Can we go ahead to the next slide? So the definition we have already discussed. So this is the entire miliary cleft which is being depicted here. So this is the eustachian tube and this is the miliary cavity, so the tympanic cavity. And then you have this Otitis, and then you have this antrum, and these are the other mastoids. So this entire cleft is called as the miliary cleft. So again, to recapitulate, it includes the eustachian tube, it includes the tympanic cavity, and it includes the Otitis, and it includes the antrum. So I told you already, so today we will be discussing about the tuberculopanic disease. So it is the same miliary cleft. So this is the diagrammatic representation. So you can see here the same eustachian tube, the same tympanic cavity, then the Otitis, the antrum, and other mastoids. So tuberculopanic disease, so the name, so tuberculopanic, tubo means the eustachian tube and the tympanic cavity main. So that is the tuberculopanic disease. So in safe type of CSOM, so this part of the miliary cleft will be involved, and then this area which is shaded in red, so that will be involved in cases of tick-borne disease. So that is the difference. So that's why this is called as tuberculopanic disease, and that is why this is called as tick-borne disease, because the attic is involved and the antrum is involved. Okay. So and the other characteristic feature of this differentiation is that, so this entire thing will be lined by respiratory epithelium. Okay, so more towards the eustachian tube, towards an esophageal end, there will be the respiratory epithelium. Then as we come inside, so it will be replaced by cuboidal epithelium. And then here in the attic region, it will be pavement-like epithelium. Means there is also cuboidal epithelium, but it will be arranged like a pavement. So it will be more compressed. So here if you see there will be more number of goblet cells, and here if you see there will be very minimal goblet cells. So that is why both the disease are different in nature because of the cellular lining of both the regions. So if you come to epidemiology, so the incidence of CSOM, especially the tympanic disease, is more common in families in which there is poor nutrition and also there is lack of health education. Means they may be having some episodes of ear discharge, but they will not address it or they will not seek any medical help. So because of which there will be persistence of infection in the middle ear cleft, and also that infection will be spreading to nearer subsites. So because of the above condition, so the condition is more common in rural areas compared to urban areas. And if you see the rural population, so this CSOM is considered as one of the important causes for hearing impairment in rural population. So that is why early identification and early treatment is necessary in cases of CSOM. So coming to the etiology, or in other words, like what are the causes? So it can be due to a sequelae of acute otitis media. So in acute otitis media, the last stage is resolution. So in resolution, if the membrane does not heal completely, that is the tympanic membrane. So after the rupture of the tympanic membrane and leading to release of pus from the middle ear cavity, so if it does not heal properly, then there can be a permanent perforation leading to CSOM. And the other cause is that any infection in the nasopharynx or in the nasal cavity or paranasal sinuses can ascend via the eustachian tube. And not just the nose and nasopharynx, any infection of the pharynx and tonsil can also ascend via the eustachian tube. And if anybody is having persistent allergy, so that is for a longer duration of time, so they will also be having a mild grade of inflammation in the middle ear cavity, leading to permanent perforation of the tympanic membrane. So what we discussed before was the cause or etiology. Now we are going to see what are the pathological changes which can happen in CSOM. So one we already discussed, there will be perforation of pars tensa. So why this perforation of pars tensa happens is that, so the tympanic membrane ruptures for any reason, and then after it ruptures, instead of healing, so the margin of the perforation will get epithelialized. So once the margin of the perforation gets epithelialized, then there is no scope for healing of the tympanic membrane. So that is why that is the inner epithelial layer and the outer epithelial layer, they fuse together, leading to epithelialization of the margin. And then the middle ear mucosa can be normal, or it can be edematous, or it can be velvety, depending on what stage of inflammation the middle ear cavity is in. So if you remember, I discussed earlier that the mucosal chronic otitis media is classified as active and inactive. So if it is inactive, then the mucosa will be normal. So if it is active, it means that some inflammation is going on, so that can be edema and velvety appearance of the middle ear mucosa. So and then polyp is usually seen in articular disease. In safe type of disease, polyp is usually not seen. And coming to the ossicular chain, so in safe type of disease, so the ossicular chain will be usually intact. But however, if the patient is having recurrent bouts of infection, like there is active infection and inflammation, so because of which there is profuse or copious amount of ear discharge inside the middle ear cavity, so that will lead to erosion of the ossicles. And the most common ossicle which is involved is the long process of incus. So because of which there can be ossicular erosion in these patients. Okay, and the next pathological change which can happen is tympanosclerosis. So what do you mean by tympanosclerosis is that, so because of recurrent inflammation, so there will be oxygen radical release. So because of this, there will be changes of hyalinization and calcium deposition. So that is why in some patients you can see a whitish plaque. So this whitish plaque can be present in the tympanic membrane, can be present in the middle ear mucosa, and it can even be present over the ossicles. So because of this, again, the patient will be having increased hearing loss, not only because of the disease, but also because of this tympanosclerosis, the patient will be having hearing loss. Okay. And as I mentioned earlier, when there is recurrent bouts of infection, so what happens is that whenever there is any inflammation or infection, the body will try to heal that process. So in that healing process, so there will be some fibrosis. Because of this fibrosis, again there will be adhesion between the ossicles, or between the ossicles and the mucosa, or between just parts of mucosa, leading to fibrosis and adhesion. So all these pathological changes can aggravate the patient's problem. So that is why we advocate the patients for surgery, because surgery is the definitive management of patients with CSOM. So if you don't counsel the patient for surgery, and if the patient does not undergo surgery, then all these pathological changes will exaggerate, and the patient's problem will also get exaggerated in terms of hearing loss and discharge. So coming to bacteriology, so these bacterial organisms changes from region to region and also from center to center, but the most common organism which is implicated in India is Pseudomonas aeruginosa, and the next is Proteus species E. coli, and the other organisms which are seen as Staphylococcus aureus and Bacteroides fragilis. So these are the common organisms which have been implicated in cases of CSOM. And if you see, actually, patients can also have multiple organisms in their ear. So if you take the ear discharge for culture sensitivity, so in some patients you can also see more than one organism. So coming to clinical features. So the most important clinical feature is that the patient will be having ear discharge. So in cases of safe type of CSOM, so the discharge will be mucoid, and it will be profuse in nature, and it will be non-foul smelling, and it will not be blood stained. So, and it will be aggravated whenever the patient is having any upper respiratory tract infection, and whenever there is any entry of water into the ear. So because of the entry of water into the ear, or because of any aggravation of upper respiratory tract infection, what happens is that, so the goblet cells near the eustachian tube and the mesotympanum and hypotympanum will be stimulated, because of which the patient will be having profuse ear discharge. Okay, and this characteristic of ear discharge you are supposed to remember, because this is very important. So in safe type of disease, the discharge will be mucoid, it will be profuse, and it will not be foul smelling, and it will not be blood stained, and it is usually aggravated by any upper respiratory tract infection and entry of water into the ear. So coming to hearing loss, so hearing loss, it will be usually conductive. So what else can be seen is that there can be a mixed type of hearing loss. So how mixed type of hearing loss can happen is that, so I told you earlier that CSOM patients will have profuse ear discharge. So what happens is that this ear discharge is filled with not just the pathological organism, that is the bacteria, but also the discharge will contain their toxins. So these toxins can percolate through the round window and the oval window, and then can enter the middle ear, and can enter the inner ear, leading to sensory type of hearing loss. So when on top of a conductive type of hearing loss, because of these toxins, sensory neural type can also happen. That is why it leads to a mixed type of hearing loss. Okay. So in CSOM, the usually hearing loss which is seen as conductive type, and because of toxins, in some cases, especially in long-standing cases, you can also see a mixed type of hearing loss. And then the degree of hearing loss, if you see, it will rarely exceed 50 decibel. So if only in CSOM patient, and the patient has a perforation with or without ear discharge, there will be a hearing loss which does not exceed 50 decibels. So in case the patient has some ossicular pathology, that is the ossicular erosion leading to ossicular discontinuity, then the degree of hearing loss can increase, going up to even 60 decibel in some patients whenever there is any ossicular involvement. Okay. So coming to perforation, so the perforation which is seen in safe type is central type. So can anyone tell what is the definition for central type of perforation? So what do you mean by central type of perforation?
So perforation involving only the pars densa.
Yeah, so perforation involving the pars densa, and also the margin of the perforation is surrounded by pars densa in all the margins or all the sides. Okay, and the classification for central type of perforation is based on the size. small, medium or moderate, large, subtotal and total. So again, past tensor is classified into how many quadrants?
4 quadrants.
Yeah, good. 4 quadrants. So in out of 4 quadrants, if one quadrant it is involved, it is small. If 2 quadrants are involved, it is medium. And if more than 2 quadrants are involved, it is large. And coming to subtotal and total, so in subtotal, the annulus will be preserved, and in total, the annulus also, fibrous annulus also will be involved. So only the ossicles will be present and they will be bare. So they will not be having any mucosal covering. So in subtotal, fibrous annulus will be preserved. In total, fibrous annulus also will be involved. Okay. So coming to the medullary mucosa, so I already discussed. So in inactive cases, it can be normal. It will be pale pink and it will be little bit moist also. So that is seen in dry CSOM. And in active cases, so you can see an inflammation of the medullary mucosa characterized by congestion, edema, and also if you see by otoscopic examination, it will be appearing like a velvet. And polyp is usually seen in articular disease, but in some cases of safe type of CSM also, polyp can be seen. Okay. So now we know the clinical features. So that is ear discharge. You already know the characteristics. Then there will be hearing loss, and there will be perforation, and also changes in the medullary mucosa. So these are the clinical features which can be seen in CSOM safe type. So what is this structure which is being highlighted here as number 1? Anyone? What is this structure? So you can see here, this is the perforation seen in the pars tensa, and what is this structure which is labeled here as number 1? So this is the handle of malleus. Okay. So what you can see here is the perforation. So you can see the margin of the perforation. It is epithelialized. That is the outer layer and the inner layer both have merged here, and it has healed fully. So because of this epithelialization only, there is no scope for this tympanic membrane to heal on its own. Okay. So this is the perforation, and through the perforation you can see the medullary structures. And what is marked here as 1 is nothing but the handle of malleus. Okay. So if this is handle of malleus, what will be this structure? Can anyone tell the answer?
Lateral process of handle.
Yeah, good. So this is lateral process of malleus. Okay. So this is handle of malleus. This is lateral process of malleus. Okay. So this part will be the pars flaccida. Okay, so this part which I am showing, that will be the pars flaccida. So the part of the tympanic membrane above this lateral process of malleus will be the pars flaccida. Okay, and what is this structure which is being shown here? What is this called as? The medial wall of medullary.
Promontory.
Promontory, good. Okay. So then you can see here, these are nothing but the hypotympanic air cells. So you can see these irregular surfaces. No? They are nothing but the air cells. They are called as hypotympanic air cells. Okay. So coming to investigations. So if a patient with CSOM presents to you, so what are the investigations you are supposed to do? Okay. So the first investigation will be examination under microscope. So when the patient presents to you, you will be examining the patient using headlight and the mirror, or you can also use otoscope. So once you confirm that it is a case of CSOM, so again for confirmation of your findings, you are supposed to do examination under microscope or EUM. So why we should do examination under microscope is that, so using the microscope, your visualization of the medullary structures is much better compared to your otoscope or headlight examination. So that is why you will be confirming the findings of the medullary. And if the patient is having discharge, then you collect the discharge and then you send for gram stain and culture sensitivity. So then again, so you will be doing suction clearance of this discharge. Okay. So for example, if this is the patient presenting to you, so then if this is the patient using microscope, you will be visualizing the structures. And if any discharge is there, you will collect that discharge and then you will send it for gram stain culture sensitivity, and then you will do suction clearance of that discharge. So for that you will have to do examination under microscope. So and then the next step will be to do a pure tone audiometry. So when you do a pure tone audiometry, so it is for documentation purposes. So you will be having a baseline hearing level of the patient. So and then you will also know what is the type of hearing loss which the patient is having, and also you will know the degree of hearing loss which the patient is having. Okay. So what is the type of hearing loss which we are expecting in CSOM safe type? Conductive type usually. Okay. And degree of hearing loss, it will not exceed how many decibels usually?
50 decibels.
50 decibels. Okay. So when you do this pure tone audiometry, so you can also use it for counseling the patient. You can explain the chart to some extent to the patient, and then you can tell the patient that this much degree of hearing loss is present, and if the PTA or the pure tone audiometry chart is showing airborne gap, then we can tell the patient that this airborne gap can be reduced if we control the infection and also if we do surgery for the patient. Okay, so that is how you counsel the patient also. So, and I discussed earlier that the ear discharge whichever is present, you will have to do culture sensitivity. So, this is a basic dictum, not just in ENT. So, in any cases, wherever there is any infection or abscess formation, so before starting antibiotic therapy, you will have to collect that pus for culture sensitivity. Because once you start the patient on antibiotic therapy, so whatever antibiotic you are giving, that will act in that area wherever there is infection, and then it will kill the bacteria. So you start the antibiotic therapy first, and then if you do culture sensitivity, then the specimen will come as sterile in most of the cases. So that is why the basic dictum, not just in CSOM, anywhere wherever you are practicing. So before you start any antibiotic therapy, you will have to send that pus for culture sensitivity. So only then, so you will be able to find out what organism is causing that infection. So and if you note here that there is no delay in therapy also, like we are not waiting for the culture report to come. So but we are just collecting that pus for culture sensitivity, and then we are sending it for culture sensitivity. And then based on wherever you are working or wherever you are practicing, empirically you will have to start the antibiotic therapy based on what is prevalent in your area. Okay. And imaging or radiological investigation, if you see, so you can do X-ray mastoid to see if there is any pneumatization or if it is a sclerotic mastoid cavity. And in cases in which you are suspecting any complication or if you are suspecting any ossicular pathology, then you can do HRCT temporal bone. Okay. So coming to treatment, so treatment will be oral toileting. That is means what? So if the patient is having discharge, then you will have to do dry mopping. So this dry mopping in ENT, any instrument you know with which you can do dry mopping? How to do this dry mopping? Any instrument which you know, which was taught to you in instruments class? Any probe?
Jobson probe.
Good.
Jobson horn probe.
Yeah, good. So we'll have to use Jobson horn probe for dry mopping. So again, which end of the Jobson horn probe? It has two ends. That is the ring end or cuvette end, and the serrated end or the pointed end. So which end will be used? The ring side or the pointed side?
Ring side.
So for dry mopping, you will have to use the serrated side or the pointed side, because the serrated side or pointed side only you will be rolling one cotton ball. So you will be rolling a part of the cotton and then you will be making it like a earbud. So you will have to use the serrated end or the pointed end for dry mopping. So you will have to roll that end and cover it with the cotton. So then after that you will have to do dry mopping. So of course the best way to treat or to give oral toileting will be to do suction clearance under microscopic visualization. Okay. So the first step is to do oral toileting in cases of active CSOM. So whenever you do this, the patient will be having lot of symptom relief. So because whenever the patient is having any ear discharge inside the ear, so it will be causing a lot of distress for the patient. So it will be very uneasy for the patient. So once you do suction clearance, the patient will be feeling lot of symptom relief. And the next thing is you will have to start the patient on antibiotic ear drops. So the commonly, what is the most common organism which is implicated? I told you earlier,
Pseudomonas.
Pseudomonas.
Okay. So Pseudomonas till now it is very much sensitive to ciprofloxacin, that is 0.3%. So however, if the irrational use of antibiotic therapy prevails, then Pseudomonas in future will become resistant to ciprofloxacin. But right now, Pseudomonas is sensitive to ciprofloxacin, so you can safely give ciprofloxacin topical ear drops. And ofloxacin, and the other antibiotics which you can give is neomycin and gentamicin. But when you are giving gentamicin or amikacin ear drops, what side effects should you be looking for? So which group of drug will they fall under, amikacin and gentamicin?
Aminoglycosides.
Good, aminoglycosides. So any complication or side effects of aminoglycosides can you think of related to ear?
Ototoxicity.
Ototoxicity, good. So patients in whom you are administering amikacin and gentamicin, you should always keep ototoxicity in mind. So that is why we routinely don't use amikacin and gentamicin unless the culture sensitivity is showing any organism which is sensitive only to amikacin or gentamicin. In such patients, we will be using amikacin or gentamicin ear drops. And another thing, if you are using amikacin and gentamicin ear drops, you should have a baseline PTA for the patient, and then you should not use these drops for more than 5 days or maximum 7 days. So if you use the drops beyond this time period, then there is more chance of the patient having ototoxicity. So once the patient develops ototoxicity or sensory neural type of hearing loss, then there is no way you can actually treat the condition. So as long as it is a conductive type of hearing loss, it is surgically treatable. But once a patient develops sensory neural type of hearing loss, you cannot treat the patient. So that is why you will have to be very careful when you are using amikacin or gentamicin ear drops. So like if the patient goes to a quack, or if the patient just goes to a pharmacist, and if they get some ear drops, and if they are giving only amikacin or gentamicin, then the patient may present to you with sensory neural type of hearing loss. And coming to systematic antibiotics or systemic antibiotics, so these antibiotics are prescribed in patients who are actually refractory to medical management, that is the topical treatment, and these are given in patients whom you don't expect them to come for regular follow-up. So if the patient in whom you are administering topical ear drops and then you are regularly doing suction clearance, then in such patients who are coming for regular follow-up, these systemic antibiotics are not usually needed. However, if the patient is from a very far area and if the patient is not able to come for regular follow-up, and in patients whom you want recovery from the active CSM very fast, then you can also start this systemic antibiotics in addition to this topical antibiotics. Okay, and these are the systemic antibiotics which we routinely use, that is ciprofloxacin 500 mg BD, plain amoxicillin 500 mg TDS, or amoxicillin plus clavulanic acid 16.5 mg BD. Okay, so again these antibiotics will change from center to center. So here we commonly use these antibiotics. So in addition to these things, you also give systemic antihistamine. So the commonly used one is levocetirizine 5 mg. So you can give either OD or BD. Okay. So the other measures, so if you remember, the one of the aggravating factors for CSOM is, I told you that whenever the patient is having an upper respiratory tract infection, or whenever the patient is taking any head bath, or whenever the patient is going for swimming, so the water can enter the middle ear cavity, stimulate the goblet cells, leading to increase in ear discharge. So any patient who is having CSOM or perforation of the tympanic membrane, you should ask the patient to prevent entry of water into the ear. So how that can be done is that, so you can advise the patient not to go for swimming, and then you should advise the patient not to take head bath. And if the patient has to take head bath, then you ask the patient to wait at least till the ear becomes inactive. And if they want to take head bath, then they will have to use cotton plugs. And these cotton plugs should be soaked with Vaseline, and then the patient has to put the cotton plug inside the ear, and then the patient has to take head bath. So these measures will prevent any exacerbation of CSOM. And also, I told you before that one of the causes for CSOM is that whenever there is any infection in the nearby anatomical sites, like the nose, paranasal sinuses, nasopharynx, tonsil, or pharynx, So if the patient has any infection in the nearby anatomical sites, then you will have to treat those infections. So only then the patient will not have any exacerbation of CSOM. Okay. So to summarize the treatment, so you will have to do oral toileting, then you will have to start the patient on antibiotic ear drops, and then systemic antibiotics on case-to-case basis, and also systemic antihistamine followed by other preventive measures. Okay. So the definitive management for CSOM will be tympanoplasty. Okay. So in your viva, so if you get a CSOM case, so first you will have to see whether it is active or inactive. So if the patient is having an active CSOM, then you will have to start from these points: oral toileting, antibiotic ear drops, systemic antibiotics, systemic antihistamine, and these measures. And then finally you will have to tell the definitive management will be tympanoplasty. But if the case which is being given to you in your exam is a dry CSOM, that is, there is no evidence of active inflammation or infection, then you should not start your answer by saying oral toileting, then topical antibiotics and systemic antibiotics. So you will have to tell the patient, tell the examiner that you will do examination under microscope, you will do pure tone audiometry, then you will counsel the patient for tympanoplasty, and if the patient is willing, then you will do tympanoplasty. Okay. So this will be the definitive treatment for CSOM safe type. Okay. So for unsafe type, if you say the surgical management is tympanoplasty, then you will not be given marks. And again, for safe type, if you say cortical mastectomy or canal wall mastectomy, then you will not be given marks. So for safe type of CSOM, the definitive management is tympanoplasty. Okay, is it clear? Okay, I hope everyone understood till now. Can we proceed?
Yes, sir.
Yes, sir.
Okay. So anybody has any doubts?
Excuse me, sir.
Yes.
I have one doubt.
Yeah.
When we say examination under microscope, does it mean only the using of otoscope and head mirror and full xylem, or there are other?
No. So here
it's different.
Yes, it's completely different. So when the patient presents to you, first you will be using either a head mirror or an otoscope. So they are completely different. So that is, the examination is using head mirror and examination using otoscope. So this is microscope. So I presume you would have seen a microscope in our OPD or in OT. So have you seen the microscope anytime?
So I saw only the using a otoscope in.
Okay. So we have an instrument called as microscope. So next time when you come for our posting or OT, so you ask one of us, we will show you the microscope. Okay, so this is different. So examination of microscope is using microscope. So you will be examining the patient's middle ear cavity, and if there's any discharge, then we'll be doing suction clearance. So this is completely different from head mirror and otoscope. Okay.
Thank you, sir.
Okay. Anybody else has any other doubts? So that examination under microscope, you can go back and you can open your book DrJTM. So in DrJTM, one diagram would have been given for examination under microscope. You can have a look at it. So I didn't put here because I thought you people would have seen the microscope. Okay. So anybody has any other doubts? Okay, then we'll wind up the class. Thank you.